I want to start off by talking about the pathophysiology of bleeding, and then I'm going to show you how primary and secondary hemostasis correlate to clinical scenarios. And then we'll talk about a few of the diseases in detail that you have to know because they're commonly tested. We have a more advanced bleeding lecture in the intern section, also labeled bleeding. All right, so we're going to start off with the pathophysiology of bleeding and clotting. And it starts off with primary hemostasis. Primary hemostasis, what happens is you've got endothelial injury. And von Willebrand factor comes out of that endothelium and acts like a Velcro and attaches to glycoproteins on platelets. This process is called adhesion. The platelets have on them a couple of receptors. Thromboxane A2 and ADP. When a platelet adheses, it gets excited and releases thromboxane A2 and ADP. This process is called activation. And as platelets release thromboxane A2 and ADP, they activate other platelets nearby, and they have a big party. The whole point of this is that there's going to be endothelial injury, von Willebrand factor, tethering a few platelets by glycoprotein 1b that get activated, calling other platelets to the party, aggregating them. And aggregation finishes with the formation of a fibrinogen mesh connected by glycoproteins 2b3a, leading to the platelet plug. So ends primary hemostasis. Secondary hemostasis is about the factors. There's an intrinsic pathway, there's an extrinsic pathway, and in the common pathway, 10, 5, 2, and 1, in that order, get activated. 1 goes to 1A. This is better known as fibrinogen, and the activated form, fibrin. And if you're paying attention, that platelet plug has on it fibrinogen. The platelet plug keeps the fibrinogen, factor 1, nearby so that this process can be activated at the site of endothelial injury and a fibrin clot can form. But if the body just allowed it to clot and there was no counterbalance, we'd clot everywhere. So we have a mechanism by which this clot is broken down into D-dimers. This process is controlled by plasmin from plasmin ogen, and plasminogen is turned to plasmin by TPA. Not surprisingly, that's why we give TPA the clot buster. The main point of this is that primary hemostasis has to do with platelets, and secondary hemostasis has to do with factors. And that is the first clinical correlation you're going to make. When someone comes in with signs and symptoms of bleeding, if it's a major bleed, you're going to get a CBC and a PT-PTT. Right? You want to know why they're bleeding, and if they have a problem with that, fix it. If the PT or the PTT are elevated, you give FFP. If the platelets are low, you give platelets. But you also want to be able to clinically reason a little bit more than that, and so I break it down like this. If someone comes in with the signs and symptoms of bleeding, especially if it's not massive hemorrhage that you're not just going to fix right away, you want to categorize this as primary hemostasis, that is platelet bleeding, or secondary hemostasis, factor bleeding. And as we said, if someone's bleeding, you're going to check a CBC, because what you're looking for is a platelet count. And you're going to check a PT, PTT to see if there's a problem with factor bleeding. But you can already separate this out into platelet or factor bleeding based on the type of bleeding, where the bleeding is occurring. Platelet bleeding is going to be very superficial. So you're going to see the gums, that is the gingiva, the vagina, which is just like the mouth, and the skin. You're going to see petechia. Petechia, gingival hemorrhage, really bad menstrual bleeding. Those are signs of primary hemostasis, problems with platelet, because those are superficial hemorrhages. Secondary hemostasis is going to present with deep bleeding, and that is going to be hemarthrosis and hematoma. So in the muscle or in the joints. Let's follow it through on primary hemostasis. If it's platelet bleeding, it's either a problem with platelet number or it's a problem with platelet function. So if you have platelet bleeding and a normal count, it is platelet dysfunction. If it's platelet bleeding and there's low platelets, that's thrombocytopenia. Thrombocytopenia has three main causes: destruction, production, and sequestration. Destruction is going to be alphabet soup, and we have the lecture that is right after this one. You're looking at ITP, TTP, DIC, and HIT, alphabet soup. Production anemias are going to be aplastic anemia. Something is wrong with the marrow, myelodysplastic syndromes, or cancers, and sequestration is going to occur in the spleen, and you're going to see this in cirrhosis primarily. When it comes to platelet dysfunction, there's a couple of things you need to consider. First, right off the bat, it might be iatrogenic, or it might be uremia. By iatrogenic, I mean antiplatelet agents. NSAIDs, aspirin, or clopidogrel. We do this on purpose to try to prevent coronary artery disease, arterial thrombosis, from platelet activation. Aspirin stops thromboxane A2, clopidogrel stops ADP. Activation is inhibited. It may be uremia, which causes platelet dysfunction. But where the test is going to go is start talking about things like von Willebrand's disease. Von Willebrand disease is deficient in von Willebrand's factor. Von Willebrand's factor stabilizes factor VIII, so you'll also have a deficiency of factor VIII. The patient is going to present platelet bleed, normal count. And they will not be on one of these agents for the test. The diagnosis is made by checking a von Willebrand factor assay. And when it is low, you can give DD-AVP to express whatever von Willebrand's factor is in their system. And in times of acute hemorrhage, you know that they will need factor VIII infusions. And they may present with a deep bleed because of factor VIII instability. In the same category as von Willebrand's disease, though they're super rare, is Bernard-Soulier and Glanzmann's thrombosthenia. Bernard-Soulier has 1B, so there's a problem with glycoprotein 1B. Glanzmann's thrombosthenia is the other one. That's glycoprotein 2B3A. Pay attention to von Willebrand's disease. Just know that Bernard-Soulier and Glanzmann's thrombosthenia exist. So now let's move it over to secondary hemostasis. You got the PT and the PTT because they were bleeding, but because you noticed their hemathroses or hematoma, you know this is going to be elevated. So when the PT and the PTT are elevated, the next thing you do is get a mixing study. You get a mixing study because you want to know, are there inhibitors or is it factor deficiency? If you give a mixing study and it does not correct, that is an inhibitor. For the MS3 level, stop here. If the mixing study corrects the bleeding time or the PT or the PTT, you have a factor deficiency. And this is where you're going to start talking about hemophilia, A or B, vitamin K deficiency, warfarin therapy, and DIC, von Willebrand's disease with its factor VIII instability. Hemophilia A and B are going to be pediatric diseases that require constant transfusions. These are the people, after they get lots of transfusions, they develop antibodies to the proteins that are in the blood. They develop inhibitors and become refractory. In hemophilia, you only give the infusion of factors when they bleed because factors are so short-lived. Instead, what you generally do is transfuse them with blood when they need them. Vitamin K deficiency can occur in the ICU patients who have been NPO for a long time. They don't eat leafy greens and they have no vitamin K. Effectively, warfarin therapy is vitamin K deficiency since we inhibit vitamin K epoxide reductase, which reduces the formation of 279 and 10 from the liver. So the person is being treated with anticoagulation that does impact secondary hemostasis. And DIC we talk about in the thrombocytopenia lecture. So this was a brief overview, but I wanted to show you that you can link primary hemostasis, platelet bleeding, to a clinical picture. And you can link secondary hemostasis, that is factor bleeding, to a clinical picture. And then you can use only a few tests to really narrow you down to where you are. We talk more about factor deficiencies in the pediatrics lectures, as well as the cirrhosis lectures. We talk about thrombocytopenia and the destruction lectures in the thrombocytopenia lecture. And then you're going to get into the production and sequestration stuff. It's kind of high order stuff that I'm going to let you read about on your own. That's bleeding.